Hello, welcome back to Behind the Filter podcast. I have my most favorite person right now back on the show. This is Ashley Regal. She's one of the co-owners of Total Body Wellness, where if you guys have been following along either on the podcast or on social media, I've been pretty open about my health journey and the autoimmune disorder that I have and the 5 million issues I've had escalate within the last 2 years that I basically have ignored. And then this lovely woman popped into my life recently, and I was like, you know what, I need to try and see if I can get my body healthy again because it's a mess. And so we ran the gamut on some tests. And so this episode, we're actually going to be going through all of it.
Yeah.
All the ugly.
Yeah.
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 So welcome back first and foremost.
Yeah. It's always so interesting because part of that first initial step is just history gathering, right? So because it's so important as a provider or whoever you're working with to find trigger words and symptoms, because it really helps direct where are we going to go with even testing.
Yeah.
And thankfully I think we nailed it when it came to what we were looking for, because boy was there a lot to find. And
oh my gosh, yes.
Yeah, so we had our initial conversation over those results, and they were really significant, which I think I'm sure as for you and as a patient, you can feel so many times hey, I know something's off, and you go maybe to your conventional provider and they run really basic testing and they're like, oh, you're fine. Mm-hmm. Everything's normal. And there's nothing more frustrating than walking away being told everything's normal when you know that you're not. And so I think it's very validating to get the right testing done, then to show actually you're not normal, and here's all the reasons why and what we need to work on.
Absolutely. Yeah. And so we found all the things.
Yeah, for
I
sure.
have to say, when we had our initial call, when I had my call with Ashley, I got off, I cried a little bit with you on the phone, and then I lost it that night, because just coming to the realization of how much of a mess my body is and has been. And not only that, I had ignored it for so long, but I think I was just trying to do it on my own. Yeah. And trying to think I know what to do. I'm, because I moved away from the traditional doctors and the specialists because it's been such a long journey for me, and just trying to do it on your own. You just cannot you need somebody to help you and to assist you, especially if you're in a situation like mine.
Yeah. Yeah. And so I know you shared that we did do a stool test, which I was pretty passionate about, even though nobody really wants to do that. I have
to tell you, everybody, even my boyfriend was like, I cannot believe you talked about your poop on social media. And I'm like, it's poop, okay? It is what it is. I don't have a gallbladder. I poop a lot.
Yeah.
It's just
everybody poops. It's a book, as a child.
Exactly.
Yeah. And it's we talked about, if we're really going to understand the root of the issue, because I think why it was so important is because you have tried a little bit of this and a little bit of that, and it just never felt like you got where you wanted to be.
Right.
And so to me, I'm like, well, then obviously it's your gut, because you can try to pour so much in, and if your GI system is so irregulated or imbalanced, then nothing is going to function the way it was meant to. Mm-hmm. Supplements, you can't process your supplements. You certainly can't process hormones well. And so maybe you have really bad side effects from something else that could be really helpful, but your gut, it angers your gut so much you can't stay on it or get therapeutic for it. And so that was really the biggest sign to me, was knowing your history with autoimmune disease and kind of seeing your journey that led you to me. Mm-hmm. And so our goal moving forward is, we're going to do this the right way, which is hard. And I know you've shared that, but we're also then going to be able to build on it continuously instead of feeling like I get a little bit better and then I slide back. Mm-hmm. And then I get a little bit better and then I slide back. So we're going to see, really great progress over time and just build on your foundations. And it's going to be awesome.
I know. I can't wait. I'm already can we fast forward?
I know.
Let's go.
Yeah.
All right. Do you want to get into some of the results?
Yeah.
And then also I'd like to talk about obviously the results of everything, and then what you are prescribing me now and that protocol too.
Yeah. So we started, most of our conversation was surrounded around your GI map. And there were a few things, if you roll the tapes, that I had guessed were low. Mm-hmm. One of them being something like Akkermansia, which is a really important organism in your gut that really, think of it as putting the padding on that mucosal layer. It helps your body break down glucose and sugar, and it builds up your layer in your gut to protect it as well. And so people who have low or no, like you had zero Akkermansia, typically have metabolic disorders, right? So weight gain is associated with that. A lot of bloating, food intolerances are all hallmark signs of low Akkermansia. You had zero.
All of it, yeah.
You had no Akkermansia, which I think was important to see. You also had a lot of what we call pathogenic bacteria. So pathogenic bacteria is bacteria that can be very opportunistic. So everything we're touching, like we're typing, then we're eating, and we're on the phone, there is bacteria that lives on everything, which is important. It helps build immunity. It is actually in ways good for our gut as well. But when you have an imbalance in other good bacteria, this opportunistic bacteria starts overgrowing. And what we saw was not enough good bacteria and way too much bad bacteria, right? And the problem with bad bacteria, again, is that it's like real estate. There's only so much room in the gut lining, and we're overgrowing bad bacteria that is, again, causing a lot of bloating. That's the number one sign of this overgrowth. Maldigestion of foods. And really when we see, which we did also see in other markers, what we call like leaky gut or intestinal wall permeability, then that bad bacteria also can leak into the bloodstream and cause more of a systemic response, specifically in autoimmune disease. And so that bad bacteria can make you feel more brain fog or fatigue and joint pain. And so we were able to identify what bacteria it was. And so how we really treat that with like understanding what to do with that bacteria is that we really go on more of like a gentle antimicrobial support, which is why I really try to avoid like antibiotics specifically, even though it could be responsive. But it's like, do we really want to drop a nuclear bomb? Or do we want to target like the invaders? And so we are able to do some targeted support for you and target those invaders. We are in this first, what I told her is, we kind of have to go in phases with your gut healing. Right now we're in really like that removal phase. Is the two biggest takeaways for me that we need to start with is you had so much bad bacteria and so much inflammation. I mean, your inflammatory markers were really off the chart.
Which makes sense because like, the amount of pain I get in my gut every time I eat anything and I bloat, it like all of a sudden it's like I'm 3-4 months pregnant. It feels that way or it looks that way. And then it's hard to the touch. And so it would happen with everything. And then that's why I was like, well, maybe it's the gluten again, or maybe it's the eggs again. And I just thought it was literally everything. So I was scared. I already knew, even like when I would go out or I'd have lunch or dinner or I'm out with my boyfriend, like I'm looking at the menu like, okay, what can I eat? Oh, well, it doesn't matter because regardless, I'm going to feel X, Y, and Z afterwards. Yeah.
So when you think about the bacteria in your gut, when you eat like super high foods and fiber, which we want to be doing, we should be doing, when with like this pathogenic bacteria that you had a lot of in abundance, as it's breaking down this fiber, it's releasing a gas, this like fermented gas. That's what makes you feel really distended and hard. And it's kind of painful. But it's a catch-22 because that fermented gas also feeds the bad bacteria. So it's like this cycle. And so your body is not able to break down fiber. And I've had patients report to me that they start avoiding these healthy foods because they honestly sometimes make them feel even worse. So they'll say, I can eat a cheeseburger and feel fine, but give me a big salad and I'm miserable. And so then you eat more cheeseburgers because you don't want to pay for it. And so that is again, another hallmark sign of overgrowth of this bad bacteria. And so for you, we are eliminating that bacteria. We're also doing some digestive enzymes to stop it ahead of time, right? And so when you start taking an enzyme before the food even hits the belly, it helps avoid that fermentation process. So we're not feeling bad and bloated, but we're also not feeding that bad bacteria.
The bad bacteria, I do have a question with that. If it goes untreated, obviously it keeps growing. It seems that way. Do you have any range if I don't know, with the testing or whatever, does it show like because of the range, like you've had it in your body for this long or is it
hard to know? But often that's where we not necessarily use like the numbers, but we could use like just medical history.
Yes.
So I've had patients come and say, oh my gosh, as a kid, I was always sick. And back then, it's like
the gut stuff started as I was a kid.
Yeah. Yeah. So if you had a lot of ear infections as a kid, so we can usually tie that to it. And your history with that definitely plays a role. But what we also saw in addition to that bad bacteria was some markers that were very, very significant to autoimmune disease. So there's a marker called calprotectin, which was very high and a really important marker to tell us like how much inflammation is in the gut. So you hear about a disease called irritable bowel syndrome, IBS, which I want to be careful with because for the most part, it is a disease of exclusion, meaning we couldn't figure anything out, a diagnosis of exclusion. So we're just going to call it IBS. But there's also something called irritable bowel disease, IBD, and that is different. And you have to have, that's not a diagnosis of exclusion. We actually have inclusive markers to diagnose that, like a high calprotectin. So you have these markers that say your bowel is not only inflamed, but it's also diseased. And so that's where not only do we take into account like moving this bad bacteria, we're in this removal phase, doing digestive enzymes and supporting that, but we also have to treat the disease of the autoimmune and the inflammation. And that's where that low dose naltrexone came in. So we really we can't treat one without the other for you. One of the other markers that was really high, which I anticipated again when we first met, was that beta glucuronidase, which I know is a big word. But if you have an elevation in beta glucuronidase, it's just recycling old hormones. Right? So whether it's hormones you're producing with your ovaries or you try some HRT, you're in perimenopause, so like, oh, progesterone would be great, but you add these hormones in and your gut can't detox them. And so you can feel worse on HRT with an elevation in this beta glucuronidase because your pathways are completely congested. And so
that makes sense because I remember how I was on HRT and it worked for a little bit and then it just stopped totally. I was like, why am I even spending this much money on this stuff?
100%. And so these detox pathways get congested. And so not only does it help you feel immediately better when you can reduce that number, but also there's associations linked to chronic elevations in beta glucuronidase and development of hormone-sensitive cancers, colorectal cancers. So it is a very important number that can be easily missed. So again, another valid reason why we invest in getting a GI map and we do the hard work up front, because if that was missed, then again, I could say, okay, let's try progesterone. Let's try testosterone. Let's try this.
It would be like this cycle that just never ending.
Yeah. And so that was extremely important to identify and so that we can treat that. And so I would say, obviously the majority of our conversation was really spent on gut because there was so much to go over. It was very clinically significant. And we use that word to describe something that had a lot of things wrong with it. And the craziest part was there's also so much more that we still needed to address. So the gut was huge. I think that, again, the inflammation, the calprotectin, the elevation in bad bacteria, no akkermansia, high beta glucuronidase, high calprotectin. It was like, okay, we've got to address this. And then there's more. We haven't even touched on your blood work yet.
Touch on the blood work. I mean, we did a little bit, but like it was so much with the gut stuff that it was insane.
So I think in summary, that's obviously our very first step, but we also identified with you some significant adrenal fatigue. And so a lot of people wonder, like, what is adrenal fatigue? How do you diagnose that? It sounds like fun. Like, I think I have that, right? Like, I'm tired too, but how do you really measure that? And we can do that through blood work, through looking at certain adrenal hormones, DHEA, pregnenolone, both of which were basically zero, meaning your adrenal function is really sluggish. And so again, it's like, well, let's give you pregnenolone, let's give you DHEA, but those are still hormone supporters. And if we don't address the issues with the gut, you wouldn't necessarily
nothing's gonna work.
Like feel better yet. But it's coming soon. I promise.
Yes.
You had remarkably low vitamin D. very low. And what's crazy about vitamin D is we think of it as, most people think like either mood, like, if I'm low in vitamin D, or immunity.
Yeah.
But there's so much more for vitamin D, even for autoimmune disease and inflammation and hormone support. And so that one's easy, right? Like the gut got real complicated how we were treating that, but the vitamin D is like, okay, take vitamin D.
And so you gave me the vitamin D load. So I did that for the first 7 days. And then I already took my one this week for Monday. And I didn't realize how, because I remember you saying people are so excited when I give them on a vitamin D load because they feel amazing. Well, I was like at the end of the week and I was like, what is she talking about? I don't feel anything. I still feel like crap. It was not until yesterday that I was at work and I was working on multiple stories and I was just going, and it hit me in the middle of the day. I was like, I'm not tired.
Yeah.
I feel okay right now.
Yeah.
So it took a good week and a half to even feel like this much of it because I was so depleted and I just couldn't believe it. I was like, wow, I was that bad.
Yeah.
In terms of vitamin D.
Yeah. So the lower you are, the more that's going to fuel inflammation.
Okay.
And so.
Yeah, I didn't know that about the vitamin D with inflammation either.
You also had really subpar thyroid function, which I also kind of assumed.
Yeah.
Just knowing your history. Right. And it's really interesting. I didn't bring up this point earlier, but we talked, if you remember, and we highlighted about thyroid and that conversion into active thyroid. 20% of T4 to T3 conversion happens in your gut. And so you were already at such a disadvantage for your thyroid to function appropriately because of all of the imbalances in your gut.
Interesting. I didn't know that either.
I know, isn't it?
Wow, that's crazy.
A lot that is so interconnected.
Yeah.
And so really how I explained it to you and what is important is just at least even in these first few weeks is let's start eliminating some of this inflammation. Let's start eliminating bacteria so that we can start adding to. And so for you, it's complicated because you're in perimenopause. And so we do, of course, want to consider hormones and hormone replacement. But again, like when does it make the most sense? We've got so much inflammation on board. I mean, remarkable inflammation. We have this gut imbalance. We're in adrenal fatigue. You have a really poor functioning thyroid. You have these vitamin deficiencies.
I am just a hot mess. Okay. I'm just a mess.
And so that's where I know it's so hard to say, like, what can I do? So we do want to balance, and even with all of our patients, because I want to earn your trust.
Yes.
And I want to earn the trust of my patients that it's like, okay, I know we're in it for the long haul, but how can I start feeling better now? Right. So that's where, like, again, load up your vitamin D. Let's get this bloating down. Like, those are two things we can do really easily. And I do think that as long as the bloating is getting better, that's where we start using science and kind of biohacking and off-label uses of something like tirzepatide or a GLP-1. Yeah. And so, semaglutide really came to, of course, market in a more, in a realm of like diabetes only. And they were talking, we've been talking about GLP-1s for several years, but when it started getting used more in a functional setting for patients who did not have type 2 diabetes, who either had metabolic disorders or, again, sugar imbalances, off weight, or inflammation, that's where I feel like it really took off. We really stopped putting it in like a box and a pigeonholed it. And then functional medicine or integrative medicine really started dipping their toes in it. It's like, wait, this isn't just for diabetes doctors. Like, I can see this used across the board in this subset of patients. And so it started getting FDA approval for other uses, right? So right now, most recently with sleep apnea, of course, weight gain. But there is a ton of data out there that shows its anti-inflammation effects. And so that's why I think adding that and layering that in is going to be so important for you. And while, of course, I know for you, like, we want to see the pounds down. But really, truly, in addition to that, what we're going to start seeing is these markers that we can track to in blood work for inflammation. Right. And so you see, like IL-6, interleukin-6, TNF-A, which is a tumor necrosis factor alpha. All of these markers are all associated with reduction on these GLP-1s. And so what you're seeing is this data supporting like autoimmune disease, even neurologic dysfunction. So there's a phenomenon in medicine called type 3 diabetes, which is Alzheimer's, and that's related to this excessive constant elevation in insulin. And so we're seeing Alzheimer's reduction in GLP-1s. And so it's really cool to see if we have the ability to use it safely and with like a trusted source. You're not like swiping up on Instagram and finding these research peptides, which is, so I just want to be really mindful of that, because you can, this was $50 cheaper from this Instagram site. I have even seen it sold on Etsy. I mean, it's crazy.
What? Are you serious? Oh my gosh.
You really want to make sure you're using an FDA approved pharmacy. So we use a local pharmacy in town, Pure Pharmacy. They have an FDA lawyer on staff at all times. They are a 503A pharmacy. They are highly regulated. And so they follow all the rules. And so they have third-party testing. So you can ensure what you're getting is pure and sterile. There's no risk for, polysaccharides or other pH imbalances in your peptide, which is the problem with research peptides. They're not intended for human use. And so people who buy these peptides online,
oh my gosh, they have no idea what they're doing.
Or they just call and they're like, it's not working. I'm like, well, it's probably because it's crap, it's just,
gosh.
And so you do risk, people get secondary infections from it, or they just risk, the biggest risk is you're just wasting your money, know. So, but for you, where I think we could really find value in this is helping bring this inflammation down. I have a lot of patients who experience, especially with these irritable bowel issues, there's a lot less inflammation in the gut. So you just don't feel like by the end of the day you're out here, which of course you're more comfortable in your skin. The weight starts coming off. And so I wanted to be mindful and not just rush to a GLP-1.
Absolutely.
I wanted to make sure you have to poop every day. You don't have excessive, reflux, because it can slow down what we call gastric emptying. That's just a side effect of any GLP-1. So I want to make sure your digestion is in a good spot before we layer that in. And I do think that we're at a good spot for that. And so in addition to gut work, which takes a while, some autoimmune treatment, which we're doing with low-dose naltrexone, and then now layering in tirzepatide, it really helps pull all these pieces together.
Absolutely.
One of the things that first off, I wanted you to start feeling better and less bloated was, of course, the digestive enzyme, which again, the science behind that is so that you're not getting this fermentation process and you're not feeding bad bacteria. It's important to take that 10 to 15 minutes prior to meals. That's probably the hardest part, especially if you're not sure when you're eating or if you're on the go.
So I did that on accident this morning because today I was off from reporting because my schedule was a little bit different this week. And so when I'm at work, I'm good. Like I set everything out, everything's fine. Well, I just wasn't in my routine. And so I ate breakfast and then I was like, shoot, my digestive enzyme. So I take it after. And then lo and behold, the bloating came back, where the digestive enzymes have really been very helpful when I've been eating. They've been tremendously, my bloating has been a lot less. And so I immediately noticed the difference this morning when I took it the wrong time. It was crazy. And I was like, all I had was cereal and water.
You also had, which we didn't talk about before, a bacteria in your upper GI tract, the H. pylori.
Oh my gosh, yes, that's right.
And so that's part of that bad bacteria. And so H. pylori, while is common, meaning 70% of most people, if you look at all people's upper GI tract, have some sort of H. pylori infection, but you had elevated levels, of course, because you've got, you're just hitting all the
everything.
And untreated H. pylori is linked to the development of peptic ulcer disease. So really can create ulcerations in your upper GI tract, and in some cases even are linked to increased risk for gastric cancers. So of course we need to treat that. What's really cool about science and data and computers is that we don't have to, again, go straight to antibiotics to treat H. pylori. There are strains of good bacteria that were discovered in labs that can treat this bacteria. And so in addition to some lifestyle and diet protocols that we discussed, we're eradicating this H. pylori, which lives pretty much from the plaque in your teeth down to your stomach. But again, that is highly associated to intolerance of foods and more nausea, just reflux, just feeling a fullness, but not in a good way. Not necessarily satiety, like, oh, I ate a good meal, I'm full, but just uncomfortable feeling when eating. When you have H. pylori, it's really important to avoid carbonation, those highly acidic foods.
That just makes you feel a lot worse.
It makes you feel worse, and it can just kind of add fuel to the fire, to the bacteria itself.
Okay. So I have been limited. I do love my Coke Zero, but I haven't had it as much.
Good. So we're going to work on reducing that.
Which that pill, there's a pill that you gave me that I opened.
Yes.
Is that to treat that? Mm-hmm. Okay.
And so the reason we have you open it and pour it in some water and mix it around is, again, because then it's starting to work again at the back of your tongue, like all the way down your throat.
Okay,
versus the stomach acid opening the capsule, like most anything else you take.
That makes
sense.
We
want it opened and working.
Okay,
from, like,
that makes sense.
all the way
At
down.
first, I was like, "Why am I'm just doing what she told me to do." I didn't know why.
And then lastly, on your gut right now is we're doing a spore biotic, which again is attracted to this pathogenic or bad bacteria. It kind of goes and works like a vacuum. It's used to treat SIBO, which is another kind of popularized term, SIBO.
I've heard of it.
Yes.
From TikTok, out of all places.
So I brought it up, which is fine. It's small intestinal bacterial overgrowth.
Okay.
Which you have, of course.
Yeah.
And spore biotics have been proven to be very effective in attracting this bacteria. In addition, in that same capsule are these immunoglobulins, and immunoglobulins or IgGs work like vacuums for the trash. And so I had said this in our phone call, and I use this a lot for patients, especially like for you. Just imagine your gut lining is just like a dry, cracked field with all this just weeds and grass. And so we're right now in this first phase of removal, we're mowing the grass and we're picking up those grass clippings along the way. Mm-hmm. So by eradicating the H. pylori and all of that other pathogenic bacteria, we're mowing the grass. These immunoglobulins are like sucking up all the waste, and we're getting that out of there. The next phase is going to be to start repairing. So thinking of tilling the soil, right? So a lot of people, which I don't blame them, like, oh my gut hurts, I'm going to take a probiotic. I'm like, well, that really isn't going to do anything. Think of that as like planting seeds on that field. Maybe one or two might survive.
Yeah.
But if you don't mow the grass, pick the grass clippings up, till that soil, you're not going to get a lot of benefit out of that.
Gotcha.
And so right now, that's what we're doing for you. Phase 1 is removal. We will move into phase 2.
The pills that I take for those, so it says to take one and then to gradually increase. When do I gradually, because right now I'm still taking one, so when do I gradually increase on those?
About every week. So it's a great question.
So then like this week I can increase it to 2.
Yes.
Okay.
Sometimes when you, like for you who have a lot of bacteria, we go slow. I mean, this is not like an acute infection. You didn't come back from Mexico and you're like, oh my gosh, I'm dying.
Yeah.
So we don't have to treat it so fast, because it can cause its own set of discomfort.
Gotcha.
So if you start at the therapeutic dose, which is 3 capsules, you could have some diarrhea or just cramping, and we just don't need, there's just no point in that. Yeah.
Got it.
So do 1 for a week, do 2 for a week, and then 3, and then we just hang out at 3.
Okay.
And the goal when treating SIBO with a spore is about 90 days. So we're going to be on that for 90 days. The Pyloguard, which is that H. pylori treatment, is only for 30 days.
Okay.
And so the digestive enzymes are going to be kind of indefinitely until you tell me your bloating's better. And after the spore is when we start, talking about tilling the soil. We'll actually do that soon. The next step for you that we'll add into my patients is it's just actually another peptide, which people are really interested in. It's a peptide called BPC-157 and a peptide called KPV. And both of those are remarkable for what you have, which is this leaky gut, inflamed gut. And what BPC does, it brings blood supply and healing to that mucosal layer.
Okay.
The KPV is what's that anti-inflammation. And so in leaky gut, think of this like your gut like channels, right? We've got all these loose channels. It's just going to help bring those channels back together, get really good blood supply. So we think about tilling the soil, right? We really want to heal that gut lining. And then then the next step after that for replacement is going to be, you need Akkermansia, right? That's that bacteria that is going to be so important to put in. Again, I don't do that right away because you probably will just poop it out. Yeah. And it's like, okay, well, we don't want to waste that.
Yeah.
But we're going to do it soon. So, we just stick with the program. And so for you and I, it's so important to be really to have close interval check-ins, and you tell me like, this is working, this is not working. I can go off the data, but what's most important is how you're feeling.
Yeah.
Right. And so we marry those together. If I know like, well, usually I do this as my protocol, but you're like, the bloating is still there, then I say, okay, well, we're going to divert and we're going to try let's take this road instead. And so the BPC with KPB, I think is going to be really good for you. Again, some other oligosaccharides and fiber that we're going to add in. We're going to add in that acromantia. It's
That's good.
all coming.
I have noticed, for the longest time, normally when you wake up, your stomach should be pretty flat. You've been sleeping and, restoring and regenerating and all of those things. And so for a while, like I would wake up just super bloated and I would be like, I don't understand. And so now I'm starting to see when I've been waking up, like the bloating has started to go down a little bit. So like one morning when I woke up, I was like, oh, wow, I don't look pregnant this morning.
Yes. I also, one of the things I'm going to send you home with today is high doses of glutamine. This is what this is called, GI Protect. And that's another way, especially in removal phase, when you are still working on getting bacteria, high doses of glutamine, again, can be so calming and healing, especially when you have a lot of pain and cramping. And so adding a scoop of this in every day is going to be great too for you. And so, so that's what we're doing for your gut health and what we're doing now and what's to come.
All right. I want to talk about the medicine that you prescribed me for my autoimmune disorder.
Yes.
Which I just find so fascinating.
I know. And that one takes a lot of time when I'm educating patients on it, because they often look at me like, what are you talking about? And so what we prescribed for you is something called low dose naltrexone. Naltrexone, it is compounded at a compounding pharmacy because it is such a small dose, which naltrexone is a medication that's been used forever in medicine. And what it is, it's an opioid receptor blocker. And so when you block opioid receptors, it sends a signal to the brain to dump epinephrine and norepinephrine and dopamine. And the reason it's used in traditional medicine settings is if, God forbid, for whatever reason, there's an overdose in opioids, like in the hospital setting, someone's waking up from surgery, they're on a morphine drip, and next thing you know, they're not breathing. You're like, oh crap. You have to immediately reverse those effects. And so there was a study in the early 1980s when they realized, you're dumping all of this dopamine. Dopamine is a endorphin, right? And so there was actually where the kind of started was, well, what if we, instead of blocking the opioid receptor, we just call it a little kiss, just a little bit, and we trickled this dopamine and epinephrine, norepinephrine. How would that work on things like mood disorders? And so if a traditional dose for someone in a hospital setting is 50 milligrams, you start at low dose naltrexone is dosed at 0.5 milligrams. And so in addition to what we know about mood and dopamine, there's this huge arm that broke off from that looked at, again, mast cell production. So in inflammation, the first thing that happens, your cells release these mast cells. Mast cells make antibodies. Antibodies attack healthy tissue. And so when we can block production of mast cells, we bring down inflammation significantly. Again, other things similarly, which is why they work synergistically together, TNF, which is that tumor necrosis factor, is blocked. There's other pathways, interleukin pathways that get blocked. And so what we find, and what is so cool, is when you can block all of these mast cells through low-dose naltrexone, you see this remarkable response in inflammation and autoimmune disease. Because the problem with autoimmune disease is that traditional treatment suppresses your immune system, right? And so while it is important and you feel better, you're sacrificing a healthy immune system. So you're also now have low white blood cell count and you're sick all the time and you can't be around large crowds, or it's like this, like which one's worse, right?
Yeah, and that's where when I first got that's how I was sick constantly, and I couldn't do anything, couldn't go anywhere, didn't want to see anybody. Somebody would look my way that thought that they were sick, I got sick. Yeah, it was horrible.
Yes, and so what's really cool about low-dose naltrexone is it doesn't suppress your immune system, it modulates it. And modulate just means that it just gets it to work back to normal.
Okay.
Right? So instead of being hyperactive and what am I going to attack? What am I going to kill? It's okay, I'm just going to chill. I'm not going to go low. I'm just going to go right back to neutral. And modulating that immune response is so helpful because it protects the organs that are being diseased. So for you, like one of them being your gut is being diseased, it helps like restore some of that healthy tissue. It doesn't attack things like bladder for like interstitial cystitis. I use it 100% of the time on patients who have Hashimoto's, rheumatoid arthritis. I will draw the blood work and do these autoimmune panels, and they'll be positive, and then within a year they're completely negative because I do their gut and I put them on low-dose naltrexone.
That's amazing.
And have absolutely no evidence of disease. And so it brings back such a high quality of life. And the other thing I love about low-dose naltrexone is I am prescribing it to you for your autoimmune dysfunction, for your high calprotectin level. But the side effects are, remember, it's good with dopamine. It helps boost your mood.
Yeah.
It's great for sleep. It's good for chronic fatigue syndrome. And so the side effects are just benefits.
They're benefits instead of side effects. Are
like what can you take in medicine that like I'm taking it for my autoimmune disease, but my side effects are going to be more energy and a better mood.
Yeah.
Like, okay, sign me up.
Yeah.
And so similar to what we were talking about with the medication or the supplement that you're taking for your gut, we do have to go very slow on low-dose naltrexone, because if you over block that opioid receptor, you're going to dump epinephrine, norepinephrine too quickly. And so you're going to just be absolutely crawling out of your skin. Heart rate goes up, respiratory rate goes up. So we ease your way up to that therapeutic dose, and we can avoid all of those side effects when it comes to like dumping neurotransmitters and too quickly. And so, so you're just now starting that. So it takes about 6 weeks to get to therapeutic dose, right? So if you follow that protocol, it takes 6 weeks to get up to 4.5 milligrams and up to 12 weeks on 4.5 milligrams to feel like full therapeutic effect.
Gotcha.
So that's another like, I'm in it for the long haul. But I always say the time passes either way.
Yeah.
So in 6 weeks, 12 weeks from now, don't you want to look back and say, I stuck with it and now I feel better.
Yes.
And so where we all struggle as human beings, as part of the human experience, is we want instant gratification.
Right.
We want to wake up and feel better. But if you trust the process and you understand the science, I feel like that helps too. So I'm so passionate about education. That way you're like, okay, I know why I'm taking this.
Yeah.
And I'm going to be more compliant taking it because I know it's coming on the other end.
Yes. And so like when you first talked about it, I was like, oh gosh, another autoimmune disease medicine, because before all the ones that I were on were horrible. Like I couldn't function. I couldn't think straight. I was very like groggy. Like the quality of life was really bad.
Yeah.
And so after a certain point, I'm like, I've got to get off of these. Like I can't live life. Like I don't know what else to do.
Right.
So I always feel like, taking medicines for that kind of is a little bit of a bad rap, because that's what's been out there.
Yeah.
So to have something that is a low dose where I don't have anything, or if the side effects they're great, then that's awesome. I think I've had some vivid dreams, but other than that, I mean, I think
that's worth mentioning if anyone ever is interested in that. I think if you're not someone who typically dreams and you start on low-dose naltrexone, that's the number one reported change.
Yeah.
Is these crazy vivid dreams. And for someone like myself, I dream, I always feel like I don't even sleep. I just transport to a different life at night. So I started low-dose naltrexone and it didn't affect me.
The other night it was super vivid that I was engaged, and so I was like, hey, to my boyfriend, I'm like, I had a dream I was engaged. He was like, oh, to who? I was like, I don't know. But it was just so funny.
Like, I had a nice
because it
ring.
was super vivid, but I couldn't see him, but I could see everything else, and I hadn't had like a super vivid dream like that in quite a while. And then the next day when I was just researching, I was like, oh, okay, that makes sense.
Yes. So it kind of works with that circadian cycle. You're spending more time in REM, and that's why there's benefits of just improved sleep on low-dose naltrexone. But if you're not used to spending so much time in certain phases of your sleep, it can be kind of a trip. When you wake up, you're like, oh my. And in very rare cases, it can increase your risk for nightmares. And it's so easy. We just have you hold it for a few nights or go back down like a stair step down in your dose. It always goes away. So it is not permanent. It always goes away. And again, so worth it on the other end.
I think one night my sleep was really off, and I did wake up very like groggy and just in a weird headspace, but then it like eventually just kind of passed. But I knew I didn't sleep good. So I was like, this is going to be a rough morning. But other than that, it was fine. Yeah. I'm grateful that there's a medicine that are people now turning to that more than anything with different autoimmune diseases instead of like the traditional medicines for their specific type of disease.
Yeah. And I think it depends on where you're at in your stage of disease. I have had some women come in with such horrible rheumatoid arthritis. They couldn't even like pick up their phone or do their job. And so what they had to go on a biologic agent. So one of those, see their rheumatologist, be on a biologic agent for a while just to get some function back. It was too far advanced. And so there is, unfortunately, you kind of have to catch it right at the right point. But she did get function back. She got in a good spot and we were able to wean down off of that and then start her on her low-dose naltrexone and avoid that. And so it just kind of depends on what the disease is and how far along you are. And so that is such a good reminder to say, be proactive with your care, right? Like, don't wait until you can't get out of bed. Try to catch it.
Yeah, because that's what I was basically like. I don't even know how I was. Yeah, I don't even know how I was living life the last 2.5 years. Honestly, it's kind of crazy. Yeah, because I barely had the energy.
Well, you should be proud of yourself that you did. You pushed through regardless.
I did, absolutely.
So that's worth, I think, praising. Is you felt that way and you still had a job. We're a mom, did a mom. It's. I think we need to give ourselves a lot of credit for that. Because it's hard because you can feel so bad and you just don't know why, or even if you do kind of know why, you don't know what to do about it. And so our goal in this space, which is why I always am so supportive of other clinics that are like mine. I have so many friends who own clinics. We really all come together and support, because the more people like you who reach out and feel better, the more people have an opportunity to learn about it. Like you're spreading the word. And so even if one person hears this and maybe they don't come to me, but they find someone like me, they're going to feel better. And so it is, to that point, more people, are doing something like low-dose naltrexone than before because they're learning about it. They're reading, they're looking at TikTok videos, and they're looking at Instagram, and they're reading Facebook pages, and they're like, okay, there is another option. I don't have to trade one bad thing for a different bad thing. I can actually upgrade instead of do just a lateral transfer on how I feel.
Exactly. It's awesome. I want to go ahead and switch to possibly the rest of my blood work that we didn't really touch on.
I know. Well, we talked about your thyroid earlier. We just kind of briefly discussed that. And I think for you, my goal will be likely to not keep you on thyroid medicine for a while. But again, we have to balance the long-term goals and also I need to feel better, right? I need energy. Your free and available T3. We talked about that last time. Normal is 2.5 to 4.5. I need you 3.5 or higher. You were 2.8. And I wasn't surprised because everything we talked about with your gut and inflammation. And so what we decided to do was start on a prescriptive T3 medication. And again, my goal is to get us through, get your energy up, kind of some of that thyroid function up. Once your gut is healed, we'll probably come off of that. So we started that. Thyroid medicine should be taken on an empty stomach. The type of medicine that was prescribed at T3 is the worst part about that one is it's twice a day. That's probably the hardest part, is how do I find an afternoon where I'm in an empty stomach in the same space. But if you can do it.
Yeah, I've been taking it the same exact time because I know that's when I'm not going to be eating.
Good. Yeah. Yes. So the goal is, when we repeat blood work, is where did that T3 shift up to? And so once we can sustain it over 3.5 and we know other things are working better, then we'll either start with one a day, go down to one a day, and then eventually off of that.
Okay.
We looked at your vitamin D, like we touched on. Your vitamin D reference range is 30 to 100. Really, if it's less than 80, it's too low. And so 80 to 100 is that sweet spot when it comes to immune function, when it comes to mood, hormone support, inflammation, and 100, in my opinion, is even a little conservative in Canada and PCOS patients. The rule of thumb is around 115, 120. Your vitamin D was 26.
Oh my gosh, I didn't realize it was that low.
Wasn't even on the reference range. And so that's where we skip ahead and we do medical grade mega doses. That's what we did, this vitamin D. I think it's this one, mega vitamin D. So the reason too, I think it's important for education, is some people will say, okay, let me go pick up a vitamin D from Costco. I probably need it. Well, Costco is somewhere between 1,000 to 2,000 international units per capsule. The mega vitamin D that I have recommended and prescribed for you is 50,000 units for one. So it's if you went to Costco, you'd have to take 50.
Oh my gosh,
just to equal one of those. So again, it's just skip that, just get, but again, dose it to your needs. I don't put everybody on this, but when you're that low, what we do is a loading dose. I'll have you take it for a full week, 50,000 units, and then just once a week. And eventually I'll switch you over to a D3, K2 combination, daily or 5 days a week, depending. But we're going to, again, right now, it's the opposite of the judicial system. You're guilty until proven innocent. Until I see your blood work, I'm not going to switch you. So we're going to stay on a high dose. We'll check labs. Once I see your vitamin D closer to 80, then we get you on a maintenance dose. So that one
I didn't realize. I knew I was like super low. I just didn't realize. Like, wow.
You weren't even like in the
I
ballpark.
wasn't even in there. Yeah.
No. We talked about your DHEA and pregnenolone. And so with your DHEA, which is, both of those are hormones that are produced by your adrenal glands. Your adrenal glands are little pyramid-shaped glands that sit on top of your kidneys. They work in promoting adrenal hormones like cortisol, right? That's probably the one we know the most, but also supportive hormones like DHEA and pregnenolone, and also testosterone. So testosterone is a unique hormone because it is produced both by either ovaries or testes and also your adrenal glands. And so with testosterone in women, when we're perimenopausal, usually we don't really peak very high in testosterone anymore, and then how much after that it left over is really dependent on our adrenal function. So your testosterone was very low. I wasn't surprised to see that. Your DHEA was going to pull up, say, typically in women around, I would say 35 to 45, I like to see their DHEA anywhere from 100 to 150. DHEA also helps produce, it's like a DHEA and pregnenolone both are grandfather building blocks to support your either estrogen, testosterone, or progesterone, depending on which one. And DHEA alone helps with things like maintaining lean muscle mass. It's good for libido, brain function, certainly skin health. You know, you're just like that crepey, dry skin as we age.
Yeah.
So again, if I went you 100 to 150, your DHEA was 46. So 3 times less than what it should be for your age.
That makes sense with the skin. So, okay, yesterday, after I picked my son up from school, I'm like, my skin hurts. And he was like, what do you mean? And I'm like, I can't explain it.
Sure.
He was like, well, like, are you hot? And I'm like, no. It just hurts. It's kind of like achy, but not achy, but I can't explain it. He was like, Mom, I have no idea what you're talking about. And I was like, I don't know either, but it hurts. Yeah. So that makes sense now. I was always wondering why my skin hurts sometimes.
It can be bad. I mean, that can also be, again, inflammation.
Yeah.
I mean, there's so much. But yeah, hormone changes make such a big difference there, and bone density, which some of these things is a hard sell because most people just don't care about their bone density. They're like, that's an old people problem, but it really matters now.
No, it matters now.
It matters now. Your pregnenolone, so again, reference range, just to put it into perspective, is 22 to 237. I love pregnenolone when reading about it and knowing what it does in the body because, again, in younger years, its main job, unlike DHEA, really kind of focuses more on testosterone and estrogen. Pregnenolone's job is to help support progesterone production. And so it's similar to when you have low progesterone symptoms, they kind of mimic some of those low pregnenolone symptoms when it comes to mood. But pregnenolone, even before it helps like as a building block to progesterone on its own, is a neurosteroid. And so why that's important is that as we age and that number goes down, there's a link to chronic low pregnenolone levels and earlier onset dementia. And so another hallmark sign of low pregnenolone hormone is like difficulty with word finding, recall. And so a lot of perimenopausal women will say, I don't know, my brain, it feels like mashed potatoes.
That's literally me.
And so
a lot of times when I'm like reporting, sometimes I just say the weirdest things, and sometimes the guys in the newsroom would be like, what did you just say? I'm like, I don't know.
Where did that come from?
I don't know where that came from.
So it's a neurosteroid, and so that one is one that we like to optimize as part of a hormone journey because, again, it can help with progesterone production in premenopausal women. It's good for brain function. It's a good mood stabilizer. We use really low doses. It's actually a supplement. It's not technically HRT. Normal pregnenolone is 22 to 232. You're at 37. I mean, and ideally we would like it around 100, not crazy high.
Yeah.
In an autoimmune disease, it's important because being a neurosteroid, there is a connection to a cascade. We don't want to make inflammation worse. And so just a very conservative amount, just again, to help with brain function and mood. That's one that we are not treating yet. The DHEA, the pregnenolone, the testosterone are all on the table right now until we get a couple things fixed, but things that we discussed.
Yeah.
And I think, again, it's important to know like the full picture. So that's why you fall under that kind of adrenal fatigue picture because those adrenal hormones are so sluggish. And so we want to like rev up adrenal function. You're still young. And so you're showing blood work as like a 60-year-old when you're 40.
I know.
So.
Gosh, that's awful.
But hey, good news is we know what it is and we know how to fix it.
Yes. I had a question about the cholesterol.
Yeah.
Because I know my numbers were off, and I don't know very much about cholesterol at all. All I know is that like kind of some of that stuff runs in my family in terms of having high blood pressure, and then it ends up turning into pre-diabetes and being diabetic and all those things. I knew it always started with all of a sudden somebody had something wrong with their cholesterol, but I never digged in. And so when I knew the numbers were off, I was like, oh no. Yes. But I don't know if that's also because of everything else that's going on with me, or if it's like hereditary.
Yes. So cholesterol is such a great topic and a kind of a hot button topic because, again, how I was trained in all of my training is like the lower the better. It's, you follow an algorithm. Once it gets to this number, you put them on a statin, you move on. And there's certainly a role for that, but it's got to be the right patient. If there's again, like an overweight patient who is type 2 diabetic and has this family history, and usually males, like sometimes a statin is the best option. But that's like one specific patient, not like a blanket statement, because cholesterol is what makes every hormone in your body. So the lower your cholesterol is, the worse off your hormones are. Your brain is mostly made of cholesterol. And so when you look at this kind of pandemic of trying to suppress cholesterol, and again, like an uptick in dementia, a lot of theories out there we're like over suppressing cholesterol and we're killing the brain. And so it's like, well, which one's worse, right? And so I do, again, want to say clearly that there is a role depending on the person. I think there's just better testing. So a traditional lipid panel, it's just not enough in my mind to ever say, oh, you need a statin or you don't.
Okay.
You have to look at other factors, like how much of the cholesterol is affecting your arteries. And so there's really cool advanced testing, most of which is hard to find, but even something like a calcium score, it's $49. You see, you're on 465 and you see a billboard for a heart scan, right? $49. You don't even need a referral. It's out of pocket, easy. It's a way to show, well, how much of these lipids are sticking to your arteries, and then it puts you at a better risk stratification. And a lot of times, again, cholesterol, if you have metabolic disease, we can fix your cholesterol with a GLP-1, with lifestyle, but because I don't want to risk, especially in these formative perimenopausal years, is like messing with your hormones, because we're really suppressing your cholesterol.
See, I didn't know any of that. Like all I knew was like if those numbers were off, they were bad, but like why,
Exactly.
Okay.
And so if you follow more of a functional approach to cholesterol, you're going to see that there's just other things you want to look at. It's your HDL, your LDL, your triglycerides are part of the picture, but not the full picture. You want to, it's like that plus insulin, plus homocysteine level, plus, if we need to do imaging, and your insulin and your homocysteine levels were great. And so I kind of liken it to like, again, like marbles in the jar, like, okay, your LDL, and we'll look at lipoproteins that stick to the LDL, like, lipoproteins, like apolipoprotein or lipoprotein B. Those are ones that tell us a little bit more about like the structure of your artery wall or how much we think is, again, sticking. So we add those marbles to the jar. And then if we feel like the jar is full, then we have to be a little bit more aggressive with how we're managing your cholesterol.
Gotcha.
But for you, the good news is that, your HDL was a little bit low. We consider that more of like a good cholesterol. It means it's light and fluffy and usually can help scoop up denser, stickier particles. So that's why a higher number is better. Your HDL was a little bit low, which again, I don't know because I haven't had enough time to follow for you. It could be due to like, a lot of times it's like more sedentary. So if you took a long period of time and you're not doing a lot of cardiovascular activity,
which obviously I've had a big change because of my immune disorder.
I know. And it's funny because even I have to remind myself this right now. For the most part, we tell perimenopausal women walk and lift weights, and like we call it a day.
Yeah.
But there still is an important role for our cardiovascular health to make sure we're getting like an opportunity each week, a couple of times a week, to get our heart rate.
Yes.
And so we don't want to forget that. The statistics alone tell us, the heart disease is the number one killer in women. We want to protect our breasts with mammograms and we want to do this and that, but we just forget about heart disease, even though we know that that's going to kill us before anything else. And so that's why I am so passionate about hormone replacement therapy, because women, like plus or minus estrogen, women prior to menopause have a 1 in 7 risk of developing a significant heart event.
Wow.
After menopause, it's 1 in 3.
Wow.
And so, it's a huge jump. And so one of the ways that we need to protect our heart is we have to do some cardiovascular activity. But it's like trying to tell someone, okay, get your walking in and then also do your resistance training. And then, also do cardio. It can be overwhelming.
It can.
And
I even find it even just with this new season of life, and now that I'm fully back into media and I'm sitting at a desk, editing, recording, being on live on air. Like before, I was up and moving around literally all day.
Yeah.
And then I'm so mentally exhausted from all of the talking I've done for the last 8 hours. The last thing I want to do is go work out sometimes when I get home from work. But I've been making myself, because I know it's part of all of this.
It is really hard, and we have a lot on our plate, and trying to balance that. And also it's like, let's be honest, the older we get, the more even personally, I don't want to do cardio.
No,
I don't like it.
No.
But when I know, I'm like, okay. And sometimes it's like, maybe you just walk on a treadmill, but you're at an elevation.
Yes.
As long as you're, like I use my Apple Watch and you can switch it when you do a workout, and I'll show you really quick, you can actually just move it to where you see your zones. Have you done that? And so if I'm just kind of paying attention, I just make sure I'm sustaining in zone 3. And so even though I'm not running, I'm not doing burpees, but I'm like, okay, I'm getting my heart rate up and I'm watching it, making sure I'm hanging out. So I just kind of move this up until I get to, I wonder if it's not going to do it for walking. I probably have to choose a different workout. But I just look at the zones. So
you look at the zones and make sure you're in that zone so that you know that's a little elevated.
Yes.
I got a walking pad in my bedroom.
Perfect.
So what I've been doing when I got home is I like to watch podcasts. And so I'll watch a podcast on YouTube and I'll put it on just a slight elevation and get my heart rate going. So that's been my go-to when I'm exhausted and I don't want to work out, but I know I have to do something.
Sure. Yeah. Yeah. So I would say as far as cholesterol goes, knowing your insulin, your homocysteine level, I think, did they do lipoproteins? When I repeat it, I'll look at lipoproteins because you had already done a cholesterol panel before me. So I'll look at your lipoproteins when I look at it, just to have a fuller picture. But no, nothing. I would say for me, I am pretty, depending again on your sex, your age, and all of these other numbers that we discussed, I'm kind of just watch the cholesterol. It responds beautifully to lifestyle and diet and everything else. So
that's great.
Again,
that's what I wanted to hear.
Yeah. I think you're good.
I want to make sure everything else is good.
Yeah.
All right. So then now, okay, so we've gotten into this first phase. So now we're still progressing because I'm still going to be documenting all of this because as we know, this is a long journey. So next will be, I think we're going to be doing an 8-week checkup. Is that correct? And then you're going to look at the numbers and draw some more blood and kind of compare to what it was to where we are at that point.
Yep.
And then would that determine kind of what the next phase will be going into?
Yeah.
Okay.
In the meantime, prior to that, like we talked about, the only changes between now and our official next appointment would be, I'm going to add in some glutamine and the tirzepatide.
Yes. So I'm looking forward to.
Yes. And then, so we'll repeat because we started you on thyroid medication. I obviously want to see what your T3 is doing. I'm going to look at your vitamin D. So if I need to adjust how we're doing your vitamin D and a few things, either if we're not addressing it or it was normal, I won't repeat that, right? I'm not gonna do a 30 tube blood panel every time you come in my office. I'm gonna really start targeting that, what I need to see. And a lot of it's gonna be, so important is just trying for you to find patterns. Is there certain parts of hormone shifts I noticed that affect my gut? Was there certain foods that I noticed? Was it my stress, my sleep? The more that you can bring to me and in correlation to daily life, it helps me always put those puzzle pieces together so I can help you find patterns too. And so we go through all of that again at that 8-week visit. We'll look at some labs and we'll talk about, okay, is there anything we can pull off that we're done with and what can we add on?
Yeah. Awesome.
The next phase.
That's great. One thing I did want to mention is I always had issues as soon as I would eat gluten. And so ever since we've started on all this, I have ate gluten and I immediately noticed I'm not getting, it's not as, in terms of what my stomach does, is not as intense.
Sure. Yeah.
So that makes me feel okay, did I not have these allergies to begin with? Because literally I thought I'm allergic to gluten, I'm allergic to eggs, I can't have X, Y, or now there was something else I couldn't eat. Oh, milk. I don't drink milk at all because I always felt like it was all of that, but it could be that because my gut is so messed up.
Exactly.
That I'm actually not allergic to all of these.
Yeah.
It's just my gut is a joke right
Yes.
now.
And so you do, in your stool sample, you do have an elevation in a marker called eosinophils, which is typically related to food. But the thing is you develop those, and that means you can also get rid of them. So it's not like, oh, I have a gluten intolerance or gluten allergy or gluten sensitivity. Those kind of people seem to intertwine those. It's like, yeah, you probably are aggravated by gluten, but it's because you're, like you said, you are in this position, your body is making little like antibodies, and we can actually test those gliadin markers. But your gliadin specifically was normal. So it wasn't gluten specifically, which is why but yes, your gut is
It's just
a hot
triggered
mess,
by,
right?
like,
It's
everything.
triggered, but you are having some responses to foods. What's hard is it doesn't tell you, like, it doesn't give you a full list of foods by just your poop. But what it's saying with an elevation in eosinophils is we know that foods aggravate you, right? And so it's just freeing to know that when you have a healthy gut, and in some cases, if there is an elevation in, let's say, gliadin, which is a peptide in the protein of gluten, I will tell you, okay, don't eat gluten, but usually it's like 90 days. It's not forever. It's just get rid of these antibodies, like get rid of the inflammation, because your healthy gut can tolerate those foods. It's just an unhealthy gut can't.
Right. Okay. This is amazing. Thank you so much. Yeah. I think just in general, people that are going to be listening to this and then also watching this is going to find it super helpful. Okay. I mean, just even me sitting here and being able to sit with you and you clearly going through everything like one by one, it like everything just clicks now. It makes sense.
Good.
And so it's great.
Good.
So thank you so much. This will be up on JohnetteCruz.com. I will make sure, I'm going to transcribe everything so that people can take a look at the article as well, just because I think it has so much more information. I'll also put everything on JohnetteCruz.com in terms of total body wellness, how you can get a hold of Ashley if you're in the area and you're looking to see somebody and have some specific issues, because obviously she's amazing and she can definitely help you if you're dealing with some things and you just need some help. You need somebody to come alongside you. So thank you so much.
Appreciate that. Yes.
All right.
Awesome.
Thank you.
Thanks.
Bye.